In Chapter 43, which starts Section 7 of the textbook, we actually roll it in with Section 7 and Sections 8 together in this course. But Section 7 begins the special patient populations, and we'll cover things such as OB emergencies, pediatrics, geriatrics, people with special health care conditions or special challenges, and then the last couple of chapters of the textbook, which will cover basic ambulance operation things that will basically be a recap. So the sort of things like rescue and hazmat and a little bit of response to disasters and whatnot. So we'll get started with 43 this week. Very heavy week. I think most of you guys, I hope, took advantage of looking at Chapter 42 actually last week, wrapped up your trauma, and then we'll be ready to roll into the new section here. So Chapter 43 over obstetrics and the care of the newborn. This is not by any means an easy section. 43 and 44 both are monstrous chapters, so very, very critical chapters, and the National Registry does concentrate quite a bit on these, being that they are generally high criticality but low volume calls. So when we have to deal with kids or we have to deal with the woman in labor, there's a lot of potential for it to go wrong, and but it's just not something we do on a regular basis. So that's why they pay particular attention to it. So we'll get started with Chapter 43 here. I do apologize, I'm feeling a little under the weather, so my voice probably reflects that as well. And don't forget that simply listening or watching the lecture is no replacement to you actually studying on your own. So our advanced education standard has finally changed from the one that we've seen the last few weeks. So now the AEMT will apply fundamental knowledge of growth, development, and aging, and the assessment findings provide basic and selected advanced emergency care and transportation for the patient with special needs. There are a couple multimedia videos that can be seen in the non-narrated PowerPoint. One over preeclampsia, which is a condition most of you guys should be familiar with already, but those of you that have been around a while, this is the onset of toxemia of pregnancy is what they used to call it, or eclampsia. And then the other one is a video of an infant delivery. There is a ton of objectives in this chapter. Actually, there's a lot of sub-objectives to each objectives, I should say. So you can see those on pages 938 through 940 in your text. We'll charge through those. All right, so occasionally a baby is born with medical problems that must be immediately corrected. And you must be able to recognize the indications of emergencies related to pregnancy and childbirth, emergencies in newborns or neonates. Generally, people who have the nice, normal, easy pregnancy don't end up calling us when it's time to give birth. In most cases, it's when something haywire happens, something weird goes wrong. So we should not generally expect when we're going to do a field delivery that everything's going to just go nice and smooth and peachy keen. Sadly, that's not the way it tends to go. Once in a while we get surprised and somebody was on their way to the hospital, their car broke down, they got a flat tire, they didn't have enough time, and all of a sudden she's like, I'm pushing, doesn't matter, I don't care if we're only halfway there, I'm pushing. Once in a while we get one of those happy stories, and we wish they were all something along those lines, that we could simply be there to really do more than catch and provide moral support. Sadly, a large number of these end up having one or two complications to go along. Although the complications aren't always a mortal or a morbid event. So to think about it, then we'll go with your case study. So we'll do a little anatomy and physiology review. The external female genitalia. So on the external female genitalia, the things that are really the most important when we're talking about obstetrics care, of course, would be the vaginal orifice. You also could, I guess, pay minor attention to the urinary meatus, but chances are you're not going to be seeing much of that. The perineum, of course, is something that's a bit on the side of concern, particularly with little ladies with big babies, because potentially there's going to be some tearing. There's not much we can do about that in the field. In the hospital, they would do an episiotomy to help make a relief cut in there so tearing or ripping didn't occur. But in most cases, in the field, we don't have time to concern ourselves with that. The mons pubis is the area that has the hair covering it. We have labia majora and minora. The labia majora are the outer regular flesh-colored lips of the vagina, whereas the labia minora are the probably a little bit pinker tones, much finer tissue there that directly surround the vagina and the clitoris and the urinary meatus. They create the vestibule. Everything within the labia minora creates the vestibule, which is really the business side of things when it comes to females' external genitalia. There are a few other things they have listed on here, mainly ducts of Bartholin glands, which really is more of a secretory function that secretes a little bit of a lubricant into the vagina. And then there's a little bit on the inside that we'll also discuss. So when we look to the inside of the female reproductive organs, we draw our attention to the uterus, which is really right there smack in the middle of the picture there. Looks like it's folded over on itself, because it really is. And the uterus is separated from the vagina by the cervix. The cervix is the opening. The opening in the cervix is referred to as the cervical os, OS. And that cervix thickens and closes off the uterus when a woman is gravid or pregnant. Additionally, we have the vagina that leads up from the vaginal orifice and from the vestibule, and that leads up then into the cervix. And on the other side, or the top side of the uterus, we have the fallopian tubes that connect into, we'll see this in a picture here in just a moment, that lead into the uterus, and they have kind of the little sweeping little fingers that brush up next to the ovary. And the ovary, approximately every 28 days while a woman is fertile, will expel a matured egg that is ready to be fertilized, in theory swept up by the fimbriae on the fallopian tubes and brought up into the top parts of the fallopian tube, where it's probably going to potentially, I shouldn't say probably, potentially going to meet with the sperm, and then will continue to travel down towards the uterus. Within a couple days, will then implant on the uterine wall and begin to grow, in theory. Additionally, some things to consider: you have the anus, which is very close by. You have the urinary bladder that sits right underneath the uterus. You have a very short urethra. The clitoris, which is primarily a sensory organ, and although there has been some discussion on whether or not the female orgasm actually plays a part in improving fertilization by dipping the cervix actually down closer into where the sperm would be, but last I knew that was still a theory. So we've talked about most of all of these here, and in childbirth, the vagina, of course, serves as part of the birth canal. So it's a multi-purpose area. So from the frontal view here of the female reproductive organs, we can now see how the ovaries are kind of suspended out there by the suspensory ligament at the ends of the fallopian tubes where the fimbriae are there, and they're trying to represent the cycle on the right side of this picture here, or what it would be if we were considering this a patient, the left side, I guess. But on the right side of the picture itself, your own right, they're trying to represent the various levels of maturation of the ova, from very, very immature up through mature and ready to be expelled, and then the recovery of the tissue. The fundus of the uterus is the top of the uterus. Typically, with a woman that's either not pregnant or within the first probably 2 months of pregnancy, your chances of being able to palpate the top of the fundus are pretty slim. But getting into the third and obviously further months above that, the fundus of the uterus is palpable. In fact, it is what they measure a lot of times from the pubic bone to the top of the fundus of the uterus. The number of centimeters generally corresponds with how far along the woman is. So once a woman reaches about 37 weeks, 38 weeks, she should be at about 38 centimeters or so. She will not, though, go above that in most cases, because then the baby will begin to drop. So it will actually start to come down a couple of centimeters as the baby's turned and the head has engaged the birth canal. So if you ever wondered. Now, when it comes to ladies who are obese, that becomes a much more difficult job to assess how far along they are by measuring the fundal height. There are much better mechanisms of computing this, including there's some lab tests that they can do looking for the HCG, which is the human chorionic gonadotropin, which is the hormone of pregnancy, as well as doing some calculations, counting backwards to the last menstrual period and calculating forward, so on and so forth. Then we have the body of the uterus. Obviously, that's the largest middle portion of the uterus there. We get down to the external os, or the cervical os, which is the opening. The fornix is kind of the little corners around the edges of the cervix, where it's really more vagina coming up to meet the cervix. And then the layers of the uterus include the endometrium, the myometrium, and there is an epimetrium out there, but we don't usually discuss it. The endometrium being the lining, that's what gets shed every 28 days if a woman does not become impregnated. Otherwise, it is prepared for implantation and for the baby to start to grow there. The myometrium being the strong muscular portion that keeps everything together, and that is what's going to be the contractile tissue that will then eventually push the baby out. And the infundibulum is kind of the funnel portion of the fallopian tube. On the end of it is the fimbriae. They don't list those, but it's F-I-M-B-R-A-E, fimbriae. Those fimbriae, remember, are the little sweeping finger-like things that pull those ejected eggs into the fallopian tube. So the uterus is a very small muscular organ. It is lined with endometrium tissue that thickens each month during the reproductive years in preparation for implantation of a fertilized ovum. Surprisingly, in the woman who has not been recently pregnant, her uterus, actually that entire system, basically from the cervix up, including the fallopian tubes and ovaries, that will fit in your hand. The whole system will fit in your hand in a woman who has not recently been pregnant. In the woman who has recently been pregnant, obviously, the uterus is going to be much, much larger. So that's going to obviously affect that. But the endometrium tissue also sometimes gets a little overgrown. And there's obviously the condition I think most people have heard of endometriosis, which is a condition of really overgrowth of scar tissue in the endometrium. And then you can also have an endometriitis. The endometriitis is when you have an inflammation and a flare-up of that endometriosis. We talked about the uppermost portion being the fundus, and the lowest portion of the cervix is the body lying between really the cervical passageway or the cervical os. The cervix is where the sperm will then enter the uterus and travel to the fallopian tubes. Okay, so if a sperm is present, fertilization generally takes place in a fallopian tube, and generally the fertilized ovum will then travel to the uterus and implant in the endometrium. Occasionally this does not happen. Occasionally it backs up and it actually goes out the fimbriae and implants elsewhere within the abdomen. Sometimes it doesn't make it all the way to the uterus before it implants, and it implants in a fallopian tube. Or sometimes it implants very weirdly, very strangely in the uterus on, say, the cervical opening. Some of these are obviously immediately non-viable pregnancies. If it travels outside, if it makes it actually, for some reason, makes it out the cervical opening into the vagina, that is not generally not an environment that is suitable or capable of allowing implantation or the growth of tissue there. Very, very different environment within the uterus than it is from the vagina. However, those within the intraperitoneal or intra-abdominal cavity there, it does happen from time to time that we have ectopic pregnancies that implant outside, and they can grow there. The most dangerous ones being the ones that implant in the fallopian tube, but they also are the most common. So in the menstrual cycle, the ovaries and the endometrium cycle monthly with endocrine changes. There are various spikes of different hormones, luteinizing hormone being a big one, and the estrogens, various estrogens that cycle and develop an egg and then eject the egg, and then in time also have created a suitable environment for implantation, that being prepared the endometrium for implantation. If implantation doesn't occur, then the woman will bleed for approximately 5 days or so, and in theory she'll lose around 30 milliliters of blood. There is a significant amount of tissue that I'm not sure they account for here, but we'll lose somewhere around 30 milliliters of blood, or so they say. So ovulation occurs 14 days after the first day of the last menstrual bleeding. So approximately 14 days after the first day that she last bled, the mature follicle will rupture, and it will discharge the ovum into the pelvic cavity near the fallopian tube. So you could say roughly 8 to 9 to 10 days after the end of her period, assuming that she has about a 5 to 6 day period, is when she is going to be the most fertile. And then so it shows here now the process of fertilization and how the discharged ovum then starts to track up the fimbriae, through the fimbriae up into the top parts of the fallopian tube, and actually not far into the fallopian tube is generally where fertilization will take place. Now, I'll have you recall the fun little trivia tidbit here that, remember, the largest human cell is a mature egg, and the smallest human cell is a sperm. So many millions of sperm all trying to get to the egg. Generally, once the egg allows one sperm in, it generally then changes chemically to not allow anything else to come in theory. After approximately 30 hours, so 12 to 24 hours after the egg was ejected, it's potentially fertilized. Approximately 30 hours into it, it's at a 2-stage cell. 40 hours into it, a 4-stage cell. And then it's an early morula, or essentially an 8-stage cell, approximately 80 hours into it. And then an advanced morula, which has hundreds of cells in it now by the time it's 4 days in. A blastocyte approximately 5 days in. And then we'll implant somewhere within about 6 to 7 days. It will then implant, causes some changing of the myometrium and the endometrium as well, and starts to then implant and grow there on the wall of the uterus. So if the sperm in the fallopian tube during ovulation, then fertilization may occur. If the pregnancy occurs, it travels then in theory down to the uterus, implants in the endometrium, and the corpus luteum secretes hormones that develop the pregnancy until the placenta has developed. And generally that hormone that we most commonly talk about is HCG, human chorionic gonadotropin. That's the one that shows up on a pregnancy test. So fertilization or conception is the union of a spermatozoon and an ovum, and they produce a zygote. Just to remember, how many chromosomes do each of those have? So you got to think about it for just a second, because remember that genetically humans have 46 chromosomes, but we get half of those from our mother and half of those from our father. So a spermatozoa has 23 chromosomes, an ovum has 23 chromosomes, and they combine to make 46. So then the zygote will have 46 because now it has combined the two. So 30 hours in, that fertilized ovum divides. 6 days in, the zygote's entering the uterus, and now starting to become what they refer to as a blastocyte. Now that sounds weird, but when you think about the term blast in human development or in biology, you really need to think of the Big Bang theory as being a blast. And in theory, that was the creation of life. Now, we're not going to debate whether or not that's true or what, but think of it as that, and a blastocyte is the creating of life. So when we have osteoblasts, those are actually cells that are creating more bone. So a blastocyst is going to be the growth of a new embryo. So the cells will then continue to divide, migrate, and we have the extra embryonic membrane start to form, or what eventually becomes known as the amniotic sac. So we now start to have this shielding, this protection starting to develop then around the embryo. We have some villi in the endometrium that will allow maternal blood to pass and fetal blood or fetal gas exchange. So kind of think of it. Actually, I think maybe we want to look at, if we can, where to go? You can look at the picture on 942. So it's the one, the bigger, the blown up picture. When we look at that, we can kind of see how there's some fissures there, or some little ditches and trenches there of the myometrium. It's kind of the interface, and what it's saying is these two things are growing next to each other and maybe have a little bit of interconnection, but yet retain their own respective systems. And with the very, very fine membranes, just like we have in the alveolus, of the lungs, we're talking very, very fine, very, very thin cell membranes and very, very small cells that are able to then pass on the or pass through, I should say, the nutrients, the waste products that baby is then going to need to continue its growth and development. So it's a fine mesh network, yet they don't, in theory, grow together. They shouldn't grow together. Occasionally that does happen. There is a medical condition that's referred to as placental accreta, and that placental accreta is when the uterus or the uterine wall and the placenta really kind of start to merge and grow together. So not particularly a fantastic situation for the mother once the baby is born. A baby that's still in utero, it's really not much of an issue, and in some cases, if there haven't been a lot of late-stage ultrasounds or reasons to believe otherwise, they may not realize that placental accreta has occurred. So it's one of those things that is fairly rare, but it can cause a life-threatening hemorrhage. In fact, put patients into DIC very quickly, and it's just not a good thing. So eventually the placenta starts to form, and that placenta is the temporary organ of pregnancy. That's the main interface. It's the lifeline. Well, the lifeline actually technically I guess would be the umbilical cord that feeds the baby and removes the waste. So here we see an example of a 28-day embryo. If you wanted to have maybe a little bit better idea of how big is this, remember at a gestational age of 1 month, we're talking about a size of about 1/4 of an inch. So this is roughly 1/4 of an inch in length. So not large at all, and weighs all of about an ounce, if that. So it's starting to now develop some rudimentary vital signs. I'm sorry, vital organs, and there is a heartbeat now beginning to form there. Now, as we look at the other end of the spectrum, at a fetus that is near term, we have everything kind of crammed in there. Everything's packed in there pretty tightly. In theory, the placenta is higher up on the uterus, and that fundus of the uterus is, 37, 38 centimeters up there. There's a little bit of amniotic fluid in there that acts as a shock absorber, kind of bathes and keeps the baby comfortable and steady. You see that this baby is already moved into the head down position, so it's possible that even the fundus of the uterus is now dropped, to 36 or so centimeters, 35 maybe, as this baby is just about ready to be born. You can take a look here, and I know the women in the audience that have been pregnant can vouch for this, and any of the men that have had pregnant wives or significant others can also speak for the amount of urination that occurs in the pregnant woman. Well, let's look right here. The baby's head is pressing right down on the urinary bladder. Even as the changes in the uterus, as this new implantation occurs, is going to start to thicken, and it's going to put a little bit of additional pressure on there. The longer she goes through pregnancy, the more her urinary bladder gets squeezed between her symphysis pubis and that baby. So hence the reason why urination becomes a very frequent trip. So for the first 60 days, or roughly 2 months, the baby is referred to as an embryo, and then from 60 days on is referred to as a fetus. So it's referred to as an embryo really because many of the rudimentary functions are all that really are there. Many of the more fine and detailed. Functions are not, and in fact it takes a while before they even lose their tail, because babies initially do have a tail in there. So normal pregnancy lasts somewhere from 37 to 41 weeks, and it is 3 13-week trimesters. So they roughly will cut it up into thirds to define certain points within the pregnancy. And a full-term infant will weigh roughly 3 to 3.5 kilograms in theory, which is 6.6 to 7.7 pounds, and be roughly 50 centimeters or 20 inches in length. I've heard of babies who have survived that have been smaller than 1 pound, and I think I recently heard that there was a 19-pound baby born here in, I don't believe it was in the United States, I actually believe it was in the Middle East, but a 19-pound baby was born. That's a whole lot of baby. So, and length of the baby varies, of course. A lot of it depends on if the baby was truly full term or not. Now, full-term babies that would only be 1 pound, that's probably not going to happen. Those are mostly very premature babies, only about halfway through the pregnancy when they hit about 1 pound. So some milestones for fetal development. So some things that we look at here. In the first gestational month, again, like I mentioned, the baby's only about a 1/4 inch in size, weighs less than an ounce, but has the very rudimentary organ systems. At 2 months, it's now about 1.5 inches in length. Still weighs less than an ounce, but the skin, the muscles, and the skeletal tissue are starting to develop. At 3 months, the fetus is now about 3 inches in length and now weighs right about 1 ounce total. And the basic central nervous system structure is complete. So this is when, if you haven't paid a lot of attention or studied a lot human growth and development, the neural tube, which is your spinal cord in your spinal column, actually is all open in the very beginning, and then it relies on the body to form tissue and envelop up around it. So when we hear about kids with spina bifida or myelomeningocele, where they have a large cyst at the bottom of their spinal column and potentially are unable to walk, but those are cases in which that neural tube did not fully close. At 4 months of age, 4 months gestation, the fetus is now roughly 5 inches in length and 5 ounces. The mother may start to feel some movement, and hair is starting to develop. At 5 months, it's now approximately 10 inches in length, weighs about 1 pound. Continuing to develop the different systems, the nares begin to open. It's another area in which requires some fusing of tissue. Your Cupid's bow or philtrum, which is the area right below your nose, those 2 little lines there are actually leftover signs of when your mouth and nose were all one cavity, and that had to form and close up. Sometimes that does not fully fuse in utero, and you end up with either a cleft palate, which is all internal, or a cleft lip and palate, in which you now have an outward sign where the lip is also open, and it leads it right up into the nose. At 6 months gestation, we're talking about 13 inches in length and 1.5 pounds. Continued development of the nervous system. The reflexes are starting to develop. The alveoli are forming. So really, we're pretty late in the ball game when we're starting to talk alveoli here. The fat deposits are being stored, although there won't be tons of them. There will be some very minor fat deposits. At 7 months, or now into the 3rd trimester, the baby is approximately 16 inches in length, weighing about 3.5 pounds, so it's about half of the weight that it will be at birth. The eyelids will open, and in males the testes will begin to descend, and in theory they will be descended by the time of birth. That doesn't always happen. At 8 months, we're now talking about an 18-inch baby, roughly 5 pounds. The alveoli are formed. The fat deposits have really increased as birth approaches. And in that last month, we have a significant amount of maturation of the respiratory system. So the systems are formed, they're functioning at the newborn level. The heart and the lungs, remember, don't fully function. Well, not a lot of the internal organs don't fully function until after birth, but they are already starting to rudimentarily start to function. So remember, no blood goes to the lungs per se when the baby's in utero, because the lungs aren't breathing oxygen in and are incapable of exhaling out. So remember, there's shunting and there's some different little trap doors that develop in there that allows blood to bypass. The heart will beat, but the lungs won't be the ones feeding it the oxygenation that it needs. It actually comes from the umbilical cord and is shunted then up through one side, through the right side of the heart into the left side of the heart, bypassing the lungs altogether, and then is pumped right back out. All right, most of the fetuses born between 25 to 27 weeks, their birth weight will be right around 600 grams or just over a pound. In general, they do not survive. Generally, 28 weeks is kind of the cutoff in which we say they have a pretty good chance of surviving. That's not to say that none of them under that age will make it. In fact, I've known a few, but the odds are stacked against them very heavily. Typically, those that do survive being born that early will have significant abnormalities, both physically and developmentally. And most of the time, they are going to require, no, not most of the time, all the time, they are going to require a neonatal intensive care unit, or a NICU. So in the Omaha area, that would either be the Nebraska Medical Center or the Children's Hospital / Methodist system. They kind of have a joint thing that they work together on. And then in Sioux City, I believe it's Mercy, if I recall correctly. And then Des Moines area would be blank, Methodist. And I believe Mercy also has a NICU. I'm not 100% sure on that one. So during pregnancy, the uterus will then increase in size, obviously. As the baby grows, the uterus has to grow. The breasts prepare for lactation, so they tend to swell. The distended uterus and the abdomen are obviously much more prone to trauma. During the first trimester, most of that abdominal content, or I should say pelvic content, remains within the pelvic bowl. So most ladies within their first trimester of pregnancy, it's fairly difficult to tell that they're actually pregnant because they may have added a little weight themselves, but it's not abundantly obvious because most of that 3-inch, 1-ounce fetus and the associated reproductive systems still is sitting down there in the pelvic bowl. So it's not until we're now knocking on month numbers 4 and 5 where now the baby's too big to sit in that pelvic bowl and it starts to migrate more upwards and outwards. A woman's blood volume will increase by 45 to 50%, and her heart rate typically goes up around 10 to 15 beats per minute. Remember, her body, the woman's body, sees the baby as an appendage. So it's like it has an extra leg to feed. And so it has to accommodate for that by having the extra blood volume. And if you have this extra blood volume, you have to have an increasing pump capacity. Well, you may have you may have a higher need for circulation, yet you don't instantly get stronger pumping capacities from your heart. So I suppose if a woman at the time she became pregnant slowly started increasing her cardio, that may help offset that somewhat, but to strengthen it and to have stronger contractions. But usually it's not enough to offset the very high increase she's going to have in necessary circulation. So during pregnancy, we have a couple of things that give us some concern. One of those being the hypertensive disorder of pregnancy, or PIH, pregnancy-induced hypertension. This can be preeclampsia or eventually leading to eclampsia. We should also be strongly suspicious for shock in the pregnant patient with trauma or non-traumatic bleeding. So because she can hide her bleeding so much better, and we're already suspecting her to have a little higher heart rate to begin with, she does have a higher blood volume, so things kind of are already somewhat compensated, yet when it gets to the point in which she starts to decompensate, that baby has already been deprived for quite some time. All right, so the combined needs of the fetus and the mother will be at least a 20% increase in oxygen consumption by the time she becomes term. And that tidal volume increases substantially, yet becomes more difficult the later in pregnancy. Because as that baby's pushing upward in the abdominal cavity, it's pushing on abdominal content. The abdominal content is pushing upwards against the diaphragm, and the diaphragm pushes on the lungs and the heart, and it just makes the whole thing kind of upsets the apple cart a little bit. It's very common for the woman to have morning sickness, and sometimes having even extreme morning sickness, or something that's referred to as hyperemesis gravidarium. This is usually the lady that doesn't have morning sickness. She has all-day sickness all day, every day. So, and that does happen. Usually they're treated with some IV fluids to help take care of their impending dehydration. Also, they may be treated with some various anti-emetic agents. Something called ondansetron is a common one, or the common name for that being Zofran. The ondansetron has become almost a miracle cure for a lot of patients. Thankfully, the price of it's come down because it used to be ridiculously expensive when it was only used for cancer patients. The gastrointestinal system will slow during pregnancy. The body is working to pick more nutrient out of what mom is eating, and not to mention the extra pressures that are being put on the abdominal contents make things not as easy to digest. Urinary frequency, like I mentioned, very common sign of pregnancy. Occasionally there will also be glucose in a woman's urine, and this is something that women will usually get to pee in a cup every time they go to see the doc, because they want to make sure there's no proteins in the urine or there's no glucose in the urine. Proteins in the urine being a sign of potential preeclampsia, and the glucose is usually evident of a person that is hyperglycemic, and they're going to hopefully head off gestational diabetes early. Sprains and strains in joints, or sprains and joint injuries are more common, and they occur much more readily for the pregnant lady, particularly the further through pregnancy that they go, as their center of gravity starts to migrate upward and outward, making them a little bit more top-heavy and easier for them to lose their balance. Occasionally, we'll also hear of some preterm labor issues, or some some false labor issues, and in this case, Braxton Hicks contractions are common in late pregnancy. They're usually intense but fairly painless, and it's a tightening in the uterus. Usually may have a few of them, and then they just kind of subside really on their own. They don't stay sustained, and once we have sustained regular uterine contraction, when we're going to be strongly suspicious that perhaps we have come upon that time. So the level of oxytocin slowly increases in the lady, and then oxytocin, or pitocin is the other name for this, will where contractions then start to become very regular and very sustained. Oxytocin is something that some paramedics will carry, or pitocin, and it's actually used by paramedics after a woman has given birth because it helps cause uterine contraction. So it helps in the case in which we have a patient that is has some excessive postpartum hemorrhage, that we would give her a couple vials of oxytocin with some IV fluids to help hopefully cause some really internal direct pressure to occur, cause that uterus to really clamp down on itself. In the hospital, it not only gets used for that, but it also is used to induce labor. So they'll give a woman a little infusion of oxytocin, and that oxytocin will hopefully then rile up the uterus and prepare the woman for labor. Now, there are 3 major stages of labor, and the first stage is from the onset of regular uterine contraction until the cervix is fully dilated. So dilation, there's actually two things that they will really discuss when it comes to the cervix, and that's dilation and effacement. So dilation is how far wide or how open is the cervix, and we're hoping that it'll be around 10 centimeters. 10 centimeters is generally considered fully dilated. OB nurses, and docs will check these ladies by placing a couple fingers in the vagina, finding the cervix, and then they will measure with their fingers how far apart or how far open is the cervix. The other thing they look at is effacement, and effacement is how thin is the cervix. So that's usually looked at more in stage 2, after the woman has become fully dilated, or getting towards fully dilated. They'll be looking at effacement. And then station, you may hear them refer to as station, and this is the position of the fetus's head with reference to the mother's pelvic outlet. So they're really kind of looking for is the baby fully engaged and ready to be born. Usually it's somewhere within stage 1, in which we have a rupture of the amniotic membrane or the bag of waters when the woman's water break. But if it doesn't break, and occasionally it even doesn't, by the time the baby's ready to be born, usually they will take a little plastic hook and hook that membrane very carefully and pop it. So basically allows the baby to finally come out once that's removed. Early on in the pregnancy, they're looking at contractions being roughly 10 minutes apart or so, slowly working their way closer and closer together. It's really when we get to contractions of about 2 minutes apart, we really start to consider that the birth is imminent, and we're going to have something happen here pretty soon. Stage 2 of the labor is the birth of the baby. So that's from the complete cervical dilation until the baby is fully out of the cervix or out of the vagina and born to the outside world. So it's the expulsion stage. It begins with the complete effacement or thinning and dilation of the cervix. Ends when the fetus is fully emerged from the birth canal. It's usually in stage 2, early stages of stage 2, when we see crowning. And crowning is when we see generally the fetus's scalp, but it's the presenting part is coming really to the birth vaginal opening or the vaginal introit. Usually as the mother has a contraction, the vagina will gape open a little bit, and we'll be able to see the top of the baby's head. As this contraction then subsides, then we may see it kind of go away until the next contraction, in which it then gapes open again. We see the baby's head. As soon as we start to see crowning, chances are pretty good that we are going to have a baby here pretty stinking soon. Parturition is the expulsion of the fetus through the birth canal, or it's the medical term for birth. Crowning, fetus's scalp. And remember that the fetus's shoulders and body are smaller than the head. Usually once the head is out, this whole thing is basically over, unless that's a really, really wide set of shoulders. And in most cases, if that's what's happened, is you guide the shoulder, one shoulder, assisting get kind of one shoulder rotated outward, and that's going to be all the shouting. That's going to be it. The third stage of labor, this is the placental stage, so this starts at the beginning after the fetus is born, and it ends when the placenta is fully expelled, and there's going to be an accompanying blood loss. It is normal to see upwards of 500 milliliters of blood loss during delivery. Remember, mom built up a huge extra amount. So in most cases, now that the baby's out of there, that extra appendage is now gone. For her to lose 300, 400, 500 cc's of blood is not a big deal. And then there's in some cases, they will refer to stage 4 being really the hour following expulsion of the placenta. They don't always refer to stage 4. Most of them refer to the 3 stages of labor. If you hear stage 4, just know that that's that first hour following the delivery of the placenta. It's really not terribly relevant to us. Okay, here they're doing an ultrasound, talking a little bit about prenatal care when it comes to our moms. Prenatal visits are obviously associated with better maternal and fetal outcomes. Yes, there have been moms who have been doing it for thousands of years without the assistance of physicians, but it's nice when the physician is involved and there's a little bit of screening, simply for the fact that hopefully being able to predict potential complications more than anything. Yeah, there may not be a lot of things that a physician can immediately do about something that's gone wrong inside. However, if they can be prepared for it at the time of birth, or if medical science has given us some proof that certain treatments, certain medications may help reverse a potential side effect or a potential birth defect, it's good that there's physician involvement. Many times they can identify fetal abnormalities. You hear really all the time about babies that are undergoing heart surgery before they're born. So they're able to get in, basically cut a little window in the uterus and get in there and do a little reparative surgery on the baby prior to its birth. So obviously the mother's going to receive a lot of advice on nutrition, medications, rest, activities, certain behaviors. Many times they're kind of limited on some of their activities that they can do, and so the role of prenatal care really, truly, I can speak, just through my experience alone of having dealt with some mothers who had no prenatal care, thinking that, well, I've been through this 3 or 4 times already, why go through it again? And come to find out that this baby is born with defects. So it's without a doubt very beneficial. Okay, so let's talk a little bit about neonatal anatomy and physiology because it is different, obviously, from that of the adult. And I will draw your attention particularly to the picture on 947 in your textbook. This picture shows you the major differences that we have in the circulatory system, in particular, of the baby, and or the fetus, I should say. So because it does not feed or does not breathe air in its lungs, doesn't feed air or feed its gut through the mouth, it takes in its nutrients, it takes in its good air, and deposits its waste out through the placenta. That's not to say that the baby doesn't build up a little bit of solid waste. It certainly does. That does reside in the baby's gastrointestinal tract, but it's a very, very small amount of a very, very thick and ugly liquid called meconium. So when the baby is born, it takes its first breath of air that changes the pressure within the chest cavity. So that pressure change alone begins a series of changes within the fetal circulation. So during the prenatal life, that blood receives oxygen from the mother's circulation. The umbilical arteries will carry the deoxygenated blood away from the fetus through the umbilical cord to the placenta, and then the umbilical vein will then pass through the liver where the blood enters the hepatic circulation to deliver nutrients on its way up to the vena cava. So we still have veins flowing towards the heart, arteries flowing away from the heart. Here we just have one more example of very few select exceptions to the rule that arteries generally have good blood and veins usually have bad blood. So additionally, to compensate for differences in oxygenation, the fetal hemoglobin is adapted for a lower oxygen environment. The fetus, while it is a high metabolism or a high, there's a lot of activity going on there, it doesn't require as much oxygen because it doesn't have to keep itself warm, and it doesn't have to perform a lot of the additional functions that it does once it becomes born. When the circulation through the umbilical cord ceases, as that cord is clamped, then the blood bypasses the umbilical arteries and will then continue into the iliac arteries. So you can see, if we look at the picture now, we can follow from the placenta. We'll follow the red vessel. Now the red vessel in this case is the umbilical vein, because it's got the good stuff in it. So that red vessel, the umbilical vein, there's one of them. There's two arteries, two umbilical arteries. Those are blue. So that umbilical vein comes in, goes into the baby via the umbilical cord to the umbilicus, of course. Part of the blood shunted into the liver for nutrient use. The other part of the blood then goes up, connects into the inferior vena cava. It will dump blood. Now, don't look at the picture on the right because that's the post-delivery picture. So you have to continue to look at the one in the full picture. Dumps it into the right atria. It then dumps down into the right ventricle, and then it shunts from, as it's pumped through the pulmonary trunk, through the foramen ovale, so it actually bypasses directly into the aorta, and then some of it also goes through the patent ductus, which passes between the pulmonary vein and the aorta.
So we have some bypassing into the right side, the left side of the heart, some bypassing right up into the aorta as pumped out. And then as we start to follow the blue back, so now we'll take the blue from the there we go. Yep, from the legs there, and we see that picks up and goes in through the umbilical arteries out to the placenta, where it then exchanges. Once the baby is born, now we can look at that inset picture on the right side there, and we'll see that the ductus arteriosus has closed, and it now becomes basically a suspensory ligament that helps hold the heart in place. And the foramen ovale that causes some of the bypass of blood from one side to the other has become closed. So there's usually that foramen ovale that allows blood to pass back and forth between the right and left sides. There should not be an opening in the ventricles, but occasionally there is. There's a ventricular defect occasionally, or ventricular septal defect, in which sometimes blood bypasses and goes through the septum into the other side. So those being our major differences in fetal circulation. Additionally, some things to think about at birth. The infant is wet and is slippery. Do not drop the baby. That's generally considered to be poor form. But if you do drop the baby, pick it up. It's a shame to have to say that. Sometimes the situation is so nerve-wracking that you might pause for a moment there. You drop the baby, you pick it up. Okay, clean it off, dry it off, warm it up. We'll check it out. It's all right. They're good. In a lot of cases, they bounce. So the head will be elongated. That's normal, of course. The elongated head is as a result of the bones in the skull shifting a little bit. The sutures in the skull, or the joints where the plates of the skull join together, have not solidified. And so they're very flexible joints there. And at the points in which multiple bone plates come together, we have the fontanelles. And there's typically 4 of them. There's the anterior fontanelle, which is the big one. If you would basically put your fingers in front of your ears and go straight up to the top of your skull, that's where the anterior fontanelle would be. That's the biggest one that stays open until about 18 months. You go, take your fingers from there and trace it back towards the crown of your head, and that's where you're going to find the posterior fontanelle. And that one actually closes up usually within about 6 to 9 months. And then there are a couple on either side of the skull, one on each side of the skull that are the lateral fontanelles that will very quickly close up themselves. So typically after birth, the neonate will then cry for a short period of time. It's been under a little bit of stress, obviously, and then usually quiets down pretty well. The normal heart rate initially will be somewhere in the 100 to 180 beats per minute. We don't usually get too concerned as long as that heart rate stays above 100. If it gets below 80, we get pretty nervous pretty quickly. If it gets below 60, we're going to start pushing on their chest. And then the normal respiratory rate will be somewhere between 30 and 60 breaths per minute. Normal systolic blood pressure, you're probably not going to take these, but the normal systolic blood pressure is somewhere in the 70 to 90 millimeters of mercury range. Body temperature 98 to 100 degrees Fahrenheit. And their organs generally should be functional. How do we know if they're functional? We don't completely know. We know ABCs, and that's what we are the most concerned with. They also have very short necks. The tongue and the head are considerably larger. The airway is funnel-shaped, and they have these very small, flat, soft noses. Neonates are obligate nose breathers, so that's the first thing that we have to be concerned with. is getting their nose cleaned out, but actually we do that secondly. There's a reason for that. Once you touch the nose, you stimulate them to breathe. So we'll suction out the mouth first. Remember that there's one mouth, there's two nares. So we suction the mouth out first to remove the largest amount of the gunk so that when they take a breath, they don't suck it in. So then we go to the nose and we suction each nostril. And by doing that, we then stimulate the baby to breathe. Once that baby has been stimulated, we can expect that they're going to probably start to breathe a little bit more regularly. Respiratory failure or rest can ensue very quickly from respiratory distress. As we're going to talk much more in the next chapter, in chapter 44, that the biggest problem that becomes life-threatening for kids is respiratory problems. So most of the time they have good, strong hearts, but it's their breathing that becomes a major issue. All right, so the developing fetus has amniotic and physiological differences that allow them to develop in this watery environment without ingesting food or breathing air. And then at birth, the fetus becomes a neonate for the first 30 days, whose body systems then have to adjust. They have to do a lot of adjustment very quickly. They have to create, be able to create their own body heat, which they don't do well, so that's why we're always keeping them all covered up and swaddled in blankets and whatnot. They have to then start to digest their own nutrients and use those. They have to be able to breathe their own air and put that to use as well. All right, so general assessment of our pregnant patient as well as management. So when responding to a call for pregnant patient, please do not overlook domestic violence. Not always is a woman having a baby a popular thing at home. Sometimes things have happened that were intended to happen, and that creates additional stress in the relationship and obviously leads to many domestic violence calls. So keep an eye out for those things as well as your own safety when it comes to those. Be alert to the indications of continuing danger and potential injuries to the mother that she may not disclose. Remember, most of the time we have people that they truly care about doing stuff, and it becomes a very taboo subject to discuss. So it could potentially be one of those things that you don't get a lot of firsthand information, and you may have to do a little bit of detective work in order to figure out what's really going on here. So don't assume the obviously pregnant patient has a chief complaint directly related to pregnancy. We go on falls and horrendous car crashes and pulmonary emboli and shortness of breath and flu-like symptoms and keep on going, occasionally even something as serious as a stroke or an MI in the pregnant patient. So it's not always directly an OB problem. Now, they may have contributing factors that came about from this being an OB issue. Pregnant ladies build up more clotting factors. More clotting factors may lead to something like an MI or a stroke or a deep vein thrombosis, but it may not directly be a pregnancy-related issue. This gives us a representation of a very common problem in the pregnant patient. It's called supine hypotensive syndrome, and you may recall that from EMT class that if you had a woman that was in the second or third trimester of pregnancy that you had to immobilize, you needed to immobilize her and then shift the weight by putting a couple rolls of towels under the right side of the backboard, patient's right side. What that does is it shifts the weight of the fetus off to the side as opposed to directly pushing down on the vena cava. And that vena cava, it's not the best representation here as what all we have going on, but if we think about it like this, there's these vessels that continue to go, down her legs, as well as feed parts of the pelvic cavity. We have all of these vessels, obviously very significant vessels that go into the legs, that are being clamped off or cut off because the pressure from this baby's weight is pressing right down on part of the vena cava or the iliac veins or what have you, and it's trapping blood down here. So we get blood that is trapped or stagnates down in this direction. And if you wanted to kind of think about it, it's sort of kind of like a compartment syndrome. It's not, but it sort of kind of is, because we have blood trapped, and blood can't continue to circulate. So with that, we have this supine hypotensive syndrome. That's why we try to shift these pregnant ladies directly off of laying flat. We want them to lay onto their left side is preferable. Doesn't have to be completely on their left side. Just shift the weight of the baby off of the midline. If the mother is unresponsive and not breathing, or not breathing normally, check for a carotid pulse. Begin CPR if a pulse is not detected. If she's unresponsive but breathing, ensure an open airway, adequate ventilation, oxygenation, and circulation. The most common cause of hypotension in the third trimester is supine hypotensive syndrome. It does sometimes crop up in the second trimester. First trimester, it's not much of an issue. The baby's still too small. And the uterus compresses that vena cava, and that reduces the blood flow back to the heart, or what we will commonly refer to as the preload, because that's the blood coming back available to be pumped next. And that will in turn decrease their cardiac output. We're going to perform our rapid medical exam or rapid trauma exam depending on our patient's situation. If that patient's not critical, perform the focused exam according to her chief complaint. Remember, this lady can have anything from, I tripped and fell, and pregnant ladies do fall very frequently. I would venture to guess that dang near every pregnant woman that I've known somewhat closely has fallen at least once and has told me about it. So it's very, very common. Now, they may not have fallen down 15 flights of stairs, may have only been a couple, but even a little bit of a fall can potentially have some pretty negative outcomes. So perform our detailed head-to-toe as time allows on our critical trauma patients or critical medical patients that we cannot identify a specific problem. Internal examination of the genitalia is not performed in the pre-hospital setting. For some reason I feel like playing with the pens tonight, but please note this. Internal examination of the genitalia is not performed in the pre-hospital setting. There are two and only two times that anything goes into the vagina in the EMS setting. One, if we have a baby who has some shoulder dystocias and the head cannot fully pass, and we cannot get air to the baby, that we have to form our own airway. So a couple fingers would go in there creating a V to create an airway for the baby. Or secondly, to take pressure off of an umbilical cord that is prolapsed prior to the baby being born, because we've got to keep the baby's head from compressing the umbilical cord. Otherwise, the baby will die. Those are the two times in which something in the pre-hospital setting goes into the vagina. All right, reasons for inspecting the external genitalia. Just because they're pregnant doesn't mean we need to inspect the external genitalia, but there are a few times in which it is important. One, we suspect trauma to the external genitalia, or even potentially to the internal organs that may be causing significant hemorrhage that can be controlled by direct pressure, or that we can detect. If we have internal bleeding that's now causing vaginal bleeding, it's important for us to know that it is present. No, there's not a lot we can do with it, but to know that it's present, it raises indexes of suspicion. Secondly, to look for perineal bulging or crowning during active labor with indications of imminent delivery. I feel like I need to push. My contractions are 1, 2, 3 minutes apart. I think the baby's coming. Those sorts of things. Those are indicative. We have a woman who's contractions maybe every 10 minutes. They're not very intense. She doesn't even look like she barely is feeling them. Chances are probably pretty good. We do not need to go scoping around down there. It may be something that you ask the lady if you are going to have a long transport time. You may want to consider having her remove her underwear, making sure that she remains covered with a sheet, just in case something would happen that we would need to get access. But in most cases, we don't need to go down there. We don't need to go looking. Whenever possible, try to have a female EMT present, or even have the female EMT do the inspection. On our secondary assessment, of course, we complete our set of vitals. We obtain a complete medical history, the best we can, and the obstetric history. Remember, there are extra things that need to be asked when it comes to our pregnant ladies. So we'll talk about a few of those here shortly. If the chief complaint indicates labor, we're going to ask some additional questions that go along with that as well. And then things such as the number of pregnancies, the number of given births, and the number of pregnancies that did not result in birth. So this comes with a little bit of additional terminology. Para and gravida. They didn't put para on here, but para and gravida. It's actually the opposite of what you might initially think it is. You might think para is pregnancy because they both start with a P, and that's not true. Gravida is pregnancy. So if you've been gravid, or think about gravity pulling the baby over their belly. So the gravida is the number of pregnancies. The para is the number of live births. And abortion, AB, I like how they also skip putting that one on there. Abortion, so we usually will use G, P, and AB as an abbreviation. So AB, abortion, that is the number of lost pregnancies or non-live births. Please note that that term has become bastardized and offensive to the general population. It does not mean what most people associate it with. Most people believe that it only has to do with induced abortion or criminal abortion, and that's not true. It has to do with any loss of a pregnancy. Prima gravidas and prima paras, that is first timers. So this would be I am pregnant with my first child. I am prima gravida. This is the first time I've given birth. I am prima para. Multigravida and multipara obviously are multiples of the respective terms. So additional questions to ask. Have you been receiving any prenatal care? Could be important. And do you suspect any problems with your current pregnancy? And did you have any problems with your past pregnancies? Some of these things continue to crop up. If you've had, say, placental abruptio placentae before, chances are probably fairly good you may have it again. If you've had a C-section in the past, there's a chance that you have a greater risk for what is referred to as uterine rupture, where the uterus actually works so hard it actually blows out. The wall gives way. Anyone who's had a C-section has at a little bit higher risk because they have that scar tissue there that is not always a stronger area, sometimes ends up being a weaker area. What is the date of your last menstrual period? Not 100% reliable, particularly in heavier ladies. that were heavier beyond at the onset of pregnancy. Sometimes the hormones and the weight and the periods don't always jive and coincide. So there are times in which ladies will have a period for a few months during their pregnancy, and there are times in which a lady will stop having her period but yet won't show other signs of pregnancy, such as a positive pregnancy test right off the bat. So it's not always 100% reliable, but in most cases, more times than not, it is. Ask about fetal movement. Have you felt it in the past? How has movement been over the last couple of days? Has it felt normal or decreased, increased, so on and so forth? Obviously, a sample history, allergies, medications, pertinent past medical history, of course, last oral intake, events leading up to, which could be interesting, asking, well, how did this happen? You may get a very explicit explanation. The chief complaint using the OPQRST, obviously some of those are not going to be appropriate. You don't get radiation of your contractions into your elbow, but you use the ones that are appropriate for the situation. Part of our clinical reasoning process, we ask about all these different medical conditions that can be aggravated by pregnancy. And new problems can arise during pregnancy. Sometimes a bit of amniotic fluid actually works its way into the circulatory system, and it's mostly at the time of birth, but works its way into the circulatory system and causes an embolus, which is, remember, embolus is a foreign body, if you will, that migrates through the circulatory system and lodges somewhere. You can get those, as well as you can get natural thrombi that break free and become free-floating emboli. So you've developed some blood clots in the legs because of decreased mobility and decreased circulation from the legs, and now all of a sudden they're let loose, they travel, they find their way, and usually get caught up in the lungs, causing a pulmonary emboli. Occasionally they make it by, and they can either affect the heart or sometimes even affect the brain, causing a stroke. It happens. I think, in fact, if I remember correctly, there was just recently a big case. Actually, I believe it was a hemorrhagic stroke, but there was actually a husband and wife that were paramedics, and the wife was obviously it was a wife that was pregnant, not the husband, but the wife was pregnant, and I believe she had a hemorrhagic stroke during her pregnancy, and it left her unresponsive and in a vegetative state. And it was in Texas because they were fighting with the state of Texas in order to remove her from life support. She was early enough in the pregnancy that that the baby was not viable. I wanted to say that she was in like the teens, number 13, 14, 15 weeks along, and there was a significant court battles that ensued because there was a law in the state of Texas that said that the way that it was interpreted, that taking the mom off of life support would end the life of the child, therefore be a form of a criminalized abortion in their state. Finally, the father, as well as the wife's family, who also agreed with the father, were able to prevail in court, removed the lady off of life support, and the mother and the baby both died. But so odd things do occur. Things such as altered mental status, seizures, hypertension, abdominal or low back pain, vaginal bleeding or discharge, leaking amniotic fluids can all be indications of pregnancy-related problems. Whether we're talking about, say, somebody who has maybe a hypoglycemic event or a hyperglycemic event for that matter because of their gestational diabetes, or they have seizures from their eclampsia of pregnancy. They maybe have a placental previa that's causing them to have some vaginal bleeding, or they've had what's called, it's abbreviated PROM, P-R-O-M, premature rupture of the membranes, a premature rupture of membranes in which they then start to leak their amniotic fluid. So all of those things are just a handful of possible potentials. So there's other oddball things that can potentially pop up as well. So patients with pregnancy complications and neonates in need of resuscitative care. Treat the mom, you'll treat the babe. People get very concerned and very wound up about what do I do, what do I do, what do I do to save the baby. In order to save the baby, you got to work hard to save the mama, because the mama is the lifeline. We do not do field C-sections or post-mortem C-sections. It is not in the scope of practice of an EMS professional. It most likely never will be in the scope of practice of an EMS professional. There are a couple of former paramedics in the state of New York who found that out the hard way. They went and were responding to a house fire, and the firefighters had removed an extremely pregnant lady who had expired. They did their assessment on the mother, and so happened to listen for fetal heart tones, in which later on in pregnancy it's possible for you to hear those if you listen in the right spots. But listen for fetal heart tones, were able to detect fetal heart tones, whipped out their OB kit with a scalpel, and did a post-mortem C-section on the mother. Delivered a baby that lived for an extremely short amount of time before it died. There were all kinds of lawsuits involved with this, and ended up with a couple of paramedics losing their licenses to practice because they were never trained to do it. They were trying to get guidance from medical control. Those people ended up being in a lot of trouble as well. Just did not end up good for anybody involved. So, so treat the mom, you treat the babe at the same time. Consider your transport destination very carefully and your need for ALS or air medical transport. We have people, we have hospitals very, very close to the Omaha metro area, as well as scattered throughout various other parts of both Iowa and Nebraska, that do not deliver babies. They don't do babies. Delivering babies is probably the most lawsuit happy thing that can happen in medicine. So if somebody's going to sue a doctor for malpractice, it's most likely going to be in OB, in obstetrics. So it is becoming cost prohibitive for many hospitals, very, very small hospitals, to continue to deliver babies. They will have the stuff on hand should an emergency delivery need to happen. And the hospital I'm thinking of, and the current class that we're recording this lecture for, we have a member that resides in this community, but they have had to deliver a few babies in really essentially in either the emergency room or the ambulance bay, because people came rushing in there thinking, well, you're our only hope, and come to find out, sorry, we don't have it. And it's so late in the process, because they diverted into this hospital to begin with, in their private vehicles on their way to, say, the Omaha area, and they've ended up delivering it in the ER, basically. So, treatment. If medications are required, the benefits of treating the mother must outweigh the risks of the medication. So we have to stop. We have to think about way back to pharmacology that we learned in the beginning of the course, and think about, oh yeah, there was that whole pregnancy category that we looked at. And remember, it's basically like your school grades. So we had A, B, C, and D's. A's are great. Should be no problem giving those to pregnant mamas. D's were really not so good. Not absolutely fail, not absolutely terrible. There's no F in pregnancy categories. It goes directly to, well, we'll take a naughty movie rating, X. So X is absolutely not. It is absolutely not good for kids. So Think of it that way. So if the medications are required, we really got to make sure that the mother can potentially, or the mother and the fetus will probably benefit from this. Some other things we have very little to worry about. Things such as dextrose-containing solutions really shouldn't be much of an issue. Many of the medications given by the AEMT are pretty safe in most cases to give. Things like albuterol. There's some potential there for them to have some tachycardias and whatnot. Little bronchodilation, a little maybe peripheral vasoconstriction. It's a category class C when it comes to pregnant ladies, but we might be, oxygen. Of course, oxygen in most cases in the pregnant lady, not a problem at all. Dextrose in many cases is I mentioned that is pretty safe. You want to be careful with what you're doing with dextrose because a little bit goes a long ways in our pregnant ladies. Other things like glucagon, really particularly safe. So we've got a lot of things to at least consider there. So in most of our life-saving measures, though, we're most likely going to be pretty safe. So we have a very rich vascular supply, so that means many complications of pregnancy and childbirth can be accompanied by hemorrhage, and that hemorrhage can eventually lead to hypovolemic shock. I mentioned much earlier in the presentation about a condition called placental accreta, where the placenta and the uterus actually mesh together and intertwine and grow together. And as the placenta starts to try to detach, it actually starts tearing chunks and bits of the wall of the uterus away, and that's not supposed to happen. And in those cases, many times the lady quickly proceeds into hypovolemic shock, and in many cases can die. So be prepared to treat shock. Many ladies that go into the OB wards end up getting an IV. However, most of them will end up with a 22 or a 20 gauge IV, which, as we know, does not always help us out when it comes to giving decent volumes of fluid. So we may need to consider, if we're going to do an alternative transport to a tertiary facility, are we going to potentially want a larger IV on this patient? It's a high-risk patient. This is somebody we're suspecting there could be some bleeding. We're going to want to consider larger bore IVs, simply for the fact to have them there precautionarily in case we need them. Treatment. So hemorrhage with the obstetrical emergencies can't be accessed and cannot be controlled by direct pressure. So when we have ladies that are bleeding from the inside, we don't have any external mechanisms to do anything about that. Even if paramedics are called and they happen to carry Pitocin or oxytocin, that's not going to benefit until the baby is out. So heavy bleeding requires intervention. It requires transport to the hospital without delay. Consider those ladies to be trauma patients, because we know that the only way to fix trauma in trauma patients is with a scalpel. So pregnant women with hypovolemic shock will have fewer signs or symptoms despite significant blood loss. Remember, they have a built-in compensatory mechanism. They have that built-in extra blood. So they're technically compensating, but what happens is while they are compensating for mom's shock, the baby is going without. So it is shunted away from the baby because the baby is an extremity to them. And it's shunted away from the baby, and everything is concentrated on saving the mother. Well, if we're monitoring the vital signs of the mother, we may see, of course, a little bit of tachycardia, which we expected to begin with. But we may not see any drops in blood pressure. Respirations went up a little bit, but that's normal, right? So we may not immediately see it. but yet that baby is suffering. So, and that placenta, like I mentioned, the placental blood flow can become very, very severely compromised, and that jeopardizes the fetus. So treatment and reassessment: manage the airway, the ventilation, oxygenation, standard supportive measures. In many cases, I've heard OB nurses say that if you're going to give a pregnant lady oxygen, give the pregnant lady oxygen via mask, for the simple fact that most pregnant ladies rely much more on their mouth to breathe than they do through their nose. However, I say if you can put them on a couple liters by cannula and get their oxygen saturation up where you need it, then that's probably going to be sufficient. But if after a minute or two on a nasal cannula you don't get oxygen up there where you want to see it, consider switching them to a mask. Avoid that supine hypotensive syndrome by positioning them slightly on their left side. Maybe you even roll up some towels or wedge a blanket underneath the right side of their body. Shifts the baby over to the left a little bit. Hopefully will help avoid that, even on the mom that's not immobilized to a board. Establish an IV access. Keep your patient warm, treat for shock, and then monitor the patient's condition. They can change very quickly. All right. The patient must feel comfortable providing you with information, and if necessary, allowing you to examine her and assist in the delivery of her baby. You must be confident, calm, knowledgeable, and professional for her to feel that she can trust you with those tasks. Okay, if you ever come down to the point in which you maybe have to do this, you probably are going to feel extremely nervous about this whole situation. And that's normal. But being prepared for it, considering the potentials, and practicing this, taking continuing education, which if you maintain your national registry, you will get a ton of OB and PEDS training every 2 years. But you're going to have to have a confident face. Even if you're scared to death, you got to show a confident air. All right, so a couple other things to consider during our critical thinking and clinical reasoning process is some potential differential diagnoses. There are all kinds of potential things that we know that can go wrong. Some of them we'll talk about a little bit more here in this chapter. Others it'll be, you'll probably run into in continuing education and whatnot. Some of them we've maybe already even discussed. So some things to consider: spontaneous abortion. Most of the time spontaneous abortion occurs pretty early in the pregnancy. So somebody who's just still in maybe their first trimester, in at least the first half of the pregnancy, could potentially have that. We're going to talk about that in a little bit. Complications of abortion. Maybe they've already aborted a fetus, or they've had a miscarriage, and but there was some retained tissues that continues to make them bleed. Dysmenorrhea, where they're having difficulties with their menses or their menstrual cycle. They may believe they're pregnant because it came late and now it's being problematic. Of course, can be pregnancy, can be complications of the pregnancy, various conditions such as placental previa or abruption, ectopic pregnancies, appendicitis, cholecystitis being, remember, if you will recall, that's the gallbladder problems. Trauma, whether it's trauma directly to the abdomen or other places. Dysfunctional uterine bleeding, urinary tract infections, pelvic inflammatory disease, endometriosis, ovarian cysts, and ovarian torsions. Some of those we've already talked about. All right, so ectopic. Ectopic pregnancy. The term ectopic means outside normal, so it does not mean in the fallopian tube. So when they say tubal pregnancy, they're only covering a certain number of the ectopic pregnancies. This is when the fertilized ovum is implanted and begins to develop somewhere other than in the endometrium within the uterine cavity. It's most often in the fallopian tube. It's also the most dangerous place for it to occur. Risk factors include scarring of the fallopian tubes from a prior pelvic inflammatory disease. We've talked about that during medical emergencies where females get repetitive infections of their abdominal pelvic cavity and can lead to that buildup of scar tissue. Endometriosis. Endometriosis, sometimes they also get a proliferation of endometrial tissue and it starts to grow in places outside the abdomen, or I'm sorry, outside the uterus. And then some forms of contraception also, particularly the IUD, that thing that looks like a letter T with a couple of strings coming off the bottom of it. That's the IUD. That the earlier ones were had a coil of copper wrapped around the little T, and that coil of copper prevented implantation. Now I believe most of them are actually chemical contraceptives. Unless the condition is recognized and managed surgically, the fallopian tube rupture will hemorrhage and it can be fatal. I mean, it's obviously fatal to